Buenas tardes. Muchísimas gracias por.
Good afternoon, and thank you very much for staying in this room today. I think it's been a very pleasing conference. Getting together has been very important. And I'd like to greet my colleague, Dr. Pavel Miranda, who is virtually present here. Hi, how are you? Pavel, it's a great pleasure to be here with you. Miguel, thank you very much. It's a real pleasure to be here with you. And thank you, everybody here. As was expected, we have the best module of the conference, and this is very important. We will start with skin and soft tissues, particularly in the melanoma scenario. Thank you very much for joining us here. Let's take advantage of the presence of our speakers. Thank you very much. Pavel, go ahead. It's a pleasure to introduce our first speaker, who is well acknowledged by all of us. He has participated in many clinical trials in melanoma, and he is an excellent speaker who has shared with us several times his experiences and knowledges. And I talk about Dr. Sanjiv Agarwala, who works at St. Luke's Cancer Center in Pennsylvania, USA. And he will give us the first talk on the updates in the management of melanoma adjuvant therapy. So please, Dr. Sanjiv Agarwala, welcome. Es un gran placer
participate in this very nice conference, and I'm very unhappy that I am not there in person, but I was not able to come. But anyway, at least it's virtual for me, and hopefully next year. I've been asked to give you a talk on adjuvant therapy of melanoma, and I think you will enjoy the session because right after me, we'll talk about neoadjuvant therapy and surgical management, etc. So this is the overview of my talk. I will start with some background, and then I will go into the data with clinical trials, focusing first on immunotherapy, then targeted therapy. We have a clinical decision to make in BRAF positive patients, so I'll show you the data there and how we make that decision. And I will end with some future directions. So let's start with the background. And you can see from this picture here, the melanoma patient journey. And, obviously they are diagnosed, have surgical treatment, and they hopefully are cured. Sometimes they are not. And there is an interval that we can intervene with adjuvant therapy, hopefully preventing the next phase, which is metastatic disease. And so there is this long time, or hopefully long time, after surgery that we can apply some kind of therapy that could improve survival, hopefully, and definitely delay relapse. So that's the basis behind why we want to do adjuvant therapy and where we do it. So let's talk about the data from clinical trials, starting with immunotherapy. And there are two agents that have been tested in melanoma immunotherapy in the adjuvant setting. As in the metastatic disease setting, historically, it was first ipilimumab, the same thing in adjuvant therapy, and then followed by anti-PD-1 agents, nivolumab and pembrolizumab. So let us start with IPI. And this, in fact, is an important trial that was conducted by URTC under the chairmanship of Dr. Lex Egermont, who is speaking right after me, so he knows this data even better than I. But it was an important study because it used the approved dose, or not the approved dose, really, the dose that was considered to be most effective, 10 milligram per kilogram of IPI versus placebo in high-risk melanoma patients. I'm not going to go into great detail, but it was a positive trial, not only for RFS, relapse-free survival, but also for overall survival. So certainly did work. The issue was that there was significant toxicity. As we know, ipilimumab is an agent that has higher toxicity than anti-PD-1, and not only the grade 4 and grade 3 toxicities, but there were 5 grade 5 toxicities as well. So this was not very much accepted in the community around the world, including the US, even though it was FDA approved. But the result was that it does work in adjuvant therapy. It has a high toxicity profile, and the dose that was used in this trial, at that time, this was a dose that was thought to be most effective, 10 milligram per kilogram, is much higher, 3 times higher than what we use in metastatic melanoma. So the question was, can we find something that is more effective, perhaps, and less toxic? And that's where the anti-PD-1 agents come into play. And I will start with nivolumab. This is an important trial, Checkmate 238, very simple design. It was a randomized trial of nivolumab versus ipilimumab. There was matching placebos, but it was a trial looking at what was the standard approved IPI dose for adjuvant therapy at that time. versus nivolumab. And the good news is that the anti-PD-1 was superior to the CTLA-4 antibody. And this is not using a placebo control, but an active control. And that's very important because the superiority is very clear. You can see on this graph, and it has a ratio of 0.71. And not only that, the toxicity was significantly lower, like you would expect with monotherapy. The toxicity was less than half of the ipilimumab data. Another important study, once again conducted by my colleague and friend Lex Egermont, who was speaking next, was this EORTC trial, and it's a Keynote 54 is the other name for it. And it's a placebo-controlled trial in this case of pembrolizumab versus placebo. And there are two parts to this trial. I'm going to focus on part one because that tells us upfront whether in high-risk melanoma, stage 3 melanoma, pembrolizumab is effective compared to placebo, and indeed it is. These were updated data recently, both looked at RFS and also distant metastasis-free survival, which is a surrogate for overall survival. And you can see that in both cases, both instances, excellent hazard ratio of 0.56 with RFS. This is a placebo control, but still a very significant result. So very clearly, anti-PD-1 agents work in adjuvant therapy, no doubt about it. And we know that at least Nivo is superior to IPI, and that means probably that Pembro is superior to IPI as well, because they're very similar results with both these agents in both metastatic disease and adjuvant therapy. Toxicity is lower, so it became a standard of care in the immunotherapy setting for high-risk melanoma, stage 3 disease, with some slight differences. There were 3A patients included in the pembrolizumab trial, not in the nivolumab trial, but essentially stage 3 melanoma is the approval. The question really is also, a few more questions come up. What about combination immunotherapy that has been effective in metastatic disease, the IPI-Nivo combination therapy? And Checkmate 915 was in fact looking at Nivo plus IPI versus Nivo alone, and there was a IPI alone control arm as well, which was dropped. Unfortunately, at the first analysis presented at AACR, there was not a superiority of Nivo plus IPI versus Nivo alone. And this really has led to a lack of enthusiasm, of course, in the adjuvant setting for combination therapy. And perhaps it is too much anyway. Monotherapy seems to work quite well. And I think, as I'll talk about later, the future advances have to be perhaps tweaking the regimen or finding biomarkers that can help us decide which patients will be treated. Another important question, what about stage 4 resected melanoma? You see this sometimes where patients have metastatic lesions, they are resectable, maybe 1 lesion or 2 lesions, they're removable. And this Immunomed trial from DCOG is the one that I think I want to focus on. And it looked at these 3 arms that you can see here. And this is a trial which actually has shown that immunotherapy is successful in stage 4 resected melanoma patients, IPI-Nivo being the most effective. But I do want to point out that in the Checkmate 238 trial, there was inclusion of patients with stage 4 melanoma that was resected as well. So we do believe that immunotherapy is a good option for patients who can have their surgical metastatic disease resected and become NED or disease-free. Important data came out at ASCO, or actually not ASCO, ESMO this year with stage 2 melanoma. And it's an important subset of patients. It is a high incidence group. And there are subsets of patients within stage 2 that don't do very well, especially stage 2C patients do very poorly. These are the ones that have ulceration. And for them, so far, there has not been an approved agent. Also, when you look at the absolute number of deaths, more patients eventually die of melanoma that start in stage 2 because stage 2 is such a larger subset as a whole. So an important group to study, and we have now results from Keynote 716, which is also a placebo-controlled trial of Pembro given in the standard dose versus placebo for stage 2 melanoma in patients above the age of 12. So they included some teenagers as well in this trial. It wasn't just adults as usual. And this result was very nice that we have a positive trial in this setting that was presented at ESMO this year. A hazard ratio of 0.65, significant p-value, showing that even stage 2 patients can benefit from adjuvant immunotherapy. In this case, pembrolizumab. We don't have data from other immunotherapy agents just yet. However, we have to keep in mind that these patients can develop toxicity. And indeed, in this trial as well, there were immune-related adverse events, hypothyroidism are the most common, but others as well. And that is a concern because many of these patients are cured without treatment. And I think it's going to be very important, once again, to identify biomarkers as to which patients among the stage 2 group will benefit the most. Of course, stage 2C, these are very high-risk patients, but some stage 2 patients, especially stage 2A, do very well, and maybe they don't need adjuvant therapy. Targeted therapy has been effective in metastatic disease. You all know this very well. So a randomized trial of dabrafenib and trametinib versus placebo control. This was done a few years ago. This was a trial that was presented by Axel Hochschild a few years back, and very dramatic and impressive difference in relapse-free survival for the combination of these targeted agents versus placebo, hazard ratio 0.51. So the result was that targeted therapy works, BRAF-MEK combination. Toxicity, by the way, was as expected, and also a new standard of care for BRAF-positive patients. So we have a journey in stage 3 melanoma that we have traversed over the last few years, going back to the ECOG trials that haven't even talked about, interferon, nobody uses that anymore. And therefore, we really have a decision for BRAF positive patients as to what we should pick as their first treatment. And we all know that in high-risk melanoma, we will do a sentinel node biopsy, establish their surgical stage, do a BRAF mutation test. And if the BRAF mutation wild type negative, they will either receive pembrolizumab or nivolumab, an anti-PD-1. No one's going to use CTLA-4 anymore based upon the data I've showed you. But the choice gets more tricky when you have a BRAF mutation positive, because you don't know which one to give first or which one to give. And we don't have randomized trials between the two approaches, even in metastatic disease right now. We don't have that data. So how do we look at this? We try to put it all together. You can see here a presentation that shows these curves. They all look very good. They're all quite similar, good hazard ratios. So comparing across trials, which we really shouldn't be doing, we have effectiveness of all these agents in both relapse-free survival and distant metastasis-free survival. So the data itself doesn't help you very much. They're both very good. When you superimpose the curves, it's interesting, with the targeted agents, the efficacy is very high initially, and then it comes down over time, very similar to metastatic melanoma, actually. But once again, there is not perfectly good data to decide as to which way to go. And I will tell you that most of us, at least right now, outside of any other analyses, will look at toxicity. And the take-home point is that with targeted therapy, toxicity is chronic. It's quite prevalent. Almost everyone has at least grade 1 or grade 2 toxicity. But you stop the drug, toxicity goes away. With immunotherapy, most patients have no toxicity with PD-1 agents, but sometimes the toxicity can be long-term and may never go away, and that's the concern. So it's a choice right now that we have to make clinically, and maybe in the roundtable we can discuss more as to what our choices are. So where is the future taking us? I think, it's a very important question, because I always struggle as a clinician with the fact that many of my patients don't need me, right? They will be cured by Dr. Egermon's surgery or Dr. Balch's surgery. They don't need me as a medical oncologist to give them a drug that may not help them. And that's the problem. We don't know who it's going to help and who it's not going to help. You can look at this analysis that some people never recur, some recur despite you treating them, and there's the people in between that benefit. And it's a small group, but it's a definite group, and it's significant statistically. But how do we make these decisions for patients as we move along and get more refined is a challenge. There are certain signals that I can show you. There's a lot to talk about, but I'll focus on a few things. And this is interesting. This Jeff Weber and the group he works with and others have shown that higher tumor mutation burden and tumor interferon gamma levels correlate with improved RFS with both Nivo and Ipi in at least in the metastatic disease trials, and in the adjuvant trials as well. This is being looked at, and there may be some kind of a role for looking at biomarkers to select patients. And Dr. Egermont is going to talk about neoadjuvant therapy, which is a fantastic area because there's so much of science there that you can explore and research that you can do. But with neoadjuvant and adjuvant therapy trials now, there is a major push to try to explore biomarkers in various ways. And I'm not going to go into detail in the interest of time. So for stage 1 melanoma, which is another group, that there are some people who die that start in stage 1 disease, and we have to figure out who they are. And there's all these pathological tests that are being looked at, like with the one with Castle Biosciences, and we don't have any definitive data to help us yet, but we need better biomarkers there. And the same thing with stage 2A disease, who does very well. We need biomarkers to select patients who to treat. Maybe we're giving too much treatment. The frequency and the intensity needs to be modified. So there are trials that are looking at, there's a trial called REFINE, Reduced Frequency Immune Checkpoint Inhibition in Cancers, that is trying to address this. And, you know, how many patients do we need to treat to get a benefit? Alex Vanakui, who used to be in Rotterdam, but now is elsewhere, you know, he has looked at this and he's doing a lot of work on that. The number of patients you need to treat to get one person to benefit. These are things that as clinicians, we have to be careful about, especially with limited resources around the world and expense of the therapy and the toxicity. And then, of course, what about combining things? There are combining adjuvant trials that are going on as well. We are taking pages out of metastatic disease and taking them into the adjuvant setting to see if they can work. Lex Egermont will talk more about neoadjuvant therapy, but I wanted to show this trial because it has an adjuvant arm that the question really is, can we one day eliminate adjuvant therapy altogether? Maybe this talk does not need to be given 5 years from now. If we can have neoadjuvant therapy that can impact the patient such that they can have neoadjuvant therapy surgery and then they are done. That would be fantastic, right? So we have to wait and see. And this is another example of a trial that's looking at neoadjuvant and then an adjuvant arm as well, that we look at which approach is better, or can we eliminate surgery altogether, even neoadjuvant therapy? And Lex will talk about that as well, I'm sure. So it's been a very nice, long, and interesting and effective journey. You know, we started a long time ago with immunotherapies like interferon that were very modestly effective, if that, with very, very high toxicity. The risk-benefit ratio was completely opposite of what we have today. And you can see where the field is now and where it's going. There are a few other trials that will mature in the next year or two, especially the NEVO trial. The REFINE trial is a good one. And I think we really have to figure out a way. As a clinician, I want to know who not to treat. You know, if I can pick those patients out, don't treat them. The ones I treat, I can benefit. That makes me feel good. It's good for my patients. It's good for the cost of healthcare, and it's good to prevent toxicity when you don't need it. So this is my last slide. I will just summarize and conclude that most patients right now with stage 3 melanoma, which is lymph node positive, and we can go into the nuances and the subsets, but essentially stage 3 disease is where the approval is. They are offered adjuvant therapy. Anti-PD-1 is an option for all appropriate patients. You can pick Nivo or Pembro. It doesn't matter. They're about the same, really, in every way you can think of, perhaps except for schedule. So that may be a reason to choose. Targeted therapy, BRAF-MEK combination, there is only one approved. That is dabrafenib trametinib, and it's for, of course, BRAF positive patients only. And the choice in those patients is still the clinical one, as far as I'm concerned. It is not a definitive decision. Some people have looked at the curves and, you know, feel that maybe with very small amounts of microscopic disease, targeted therapy is the right way to go. I don't know. I must say, honestly, I don't know what the answer is right now. I think it's still a clinical decision. It's good news for stage 2 patients now, especially stage 2C. I was looking for something for them for a long time. I would try to treat them, but I would not get the insurance approval. Now I can get them treated. We have at least pembrolizumab is effective in stage 2 melanoma. And there are multiple clinical trials going on to further refine our options and our choices. So I will stop here and turn it over back to Pavel and the next talk, and we'll be happy to participate with the Q&A at the end of the session. Thank you.
Muchas gracias por su excelente participación.
Thank you very much for your excellent presentation, Dr. Sanjiv. We will leave questions for the end of the whole module, if you allow me. And now I'd like to introduce our next speaker, who is well known by all of us, Dr. Alexander Egermont, who is a surgeon oncologist who has participated, as you have been able to see, in multiple studies. He was director of the and at present he is CSO of the Princess Maxima Center. He will talk about the revolution of neoadjuvants. So Dr. Alexander Eggerman, thank you, welcome, and thank you for accepting our invitation.
Thank you. So I'll start sharing the screen. Let's see if everything works the way it's supposed to work. So can I get a confirmation that you can see my slide?
No aún, pero
It should be emerging right now.
Yeah, no, we can see it, Alex.
Yeah, now it's fine, right? Yeah, there's a little time lag because of the distance. So I'll start. Thank you. So, dear friends in Mexico, and dear Hector Martinez Said, my dear friend who spent half a year in my department in Rotterdam at the time, I'm very happy to be with you and to discuss with you what I think is going to determine the next 5 years in melanoma, changing the landscape of how we manage melanoma and how we, in the end, may replace many adjuvant therapies by a neoadjuvant approach, and how this whole neoadjuvant immunotherapy revolution will be rolled out across multiple tumors. So let me see if my slide wants to advance. Here are my disclosures, and let's get started. So we have 2 key immunomodulators that basically unblock a blocked immune system. We have anti-CTLA-4 that allows for continued T-cell priming, which leads to an increase in T-cell clones, both in variety as well as in amplitude. Now, those T-cell clones that do express PD-1 on their surface as activated cytotoxic T-cells, they go into the circulation and they will go into the metastatic sites. And that's where they, as effector cell function, will start to kill tumor cells. However, at the tumor site, that PD-1 expression on these activated T cells will be ligating with PD-L1 expression on tumor cells and on macrophages, and that interaction paralyzes, neutralizes the effector cell function of the T cells, and so in the end, you don't get tumor cell kill. And so the anti-PD-1 molecules and anti-PD-L1 molecules have turned out to be crucial facilitators and protectors of T-cell effector function. Well, when we look at the overall picture landscape of treatments in advanced disease, non-resectable metastatic disease, you see a top curve, and that's the combination of anti-CTLA-4 plus anti-PD-1. You see that just below that curve is the curve, which is a bit orange, and it's the curve of anti-PD-1 monotherapy. And then we hit a dark green curve. And that dark green curve is just a little bit better in the first 10 to 12 months. But it works for BRAF mutant melanoma patients only because it's the BRAF-MEK inhibitor combinations. What you see is that in efficacy, the immuno-oncology, the anti-PD-1 based regimens, whether it's monotherapy or the combination of anti-CTLA-4 and anti-PD-1, become superior in efficacy in advanced melanoma from month 12, 13, 14th on, and that they become more and more superior for these BRAF mutant melanoma patients. So what is the end situation here? Is that basically right now, nothing can stand in the shadow of immunotherapy and immunotherapy combo therapy. So the next question then, of course, is, does the landscape in advanced melanoma, where we now have effective treatments, translate into efficacy in the adjuvant setting? And yes, there is a linear and direct correlation between the outcomes in advanced disease into adjuvant setting. And Dr. Sanjiv Agarwala, another great friend of mine, he has just told you about that. And he has told you that what I show here on the summary slide, ipilimumab was the first agent in metastatic disease. It was the first approved agent in the adjuvant setting. Nivolumab, the anti-PD-1, is better in the advanced disease than ipilimumab, and it's better in the adjuvant setting, as was demonstrated in the CheckMate 238 trial. For BRAF mutant melanoma patients, you have an alternative. It's the BRAF-MEK combo, dabrafenib plus trametinib, and there's another anti-PD-1 agent, the pembrolizumab agent, which was also shown to be superior in the adjuvant setting. So everything is consistent in terms of the translation from advanced into adjuvant. Let's not forget that when you look at long-term results of adjuvant ipilimumab, hazard ratios for relapse-free survival, distant metastasis-free survival, and overall survival are all the same. They're 0.75, 0.76, 0.73. So it does translate also into an overall survival benefit, but there was only 25% crossover in this trial for the placebo arm. The problem here was, as Agarwala illustrated, was the high dose ipilimumab, and you don't need more than 3 milligrams per kg. But perhaps at the lower dose of ipilimumab, there is a threshold where it's active and where it's not active anymore. And so where it's active is at the 3 milligram level, and that's the German trial. I need to go into this data in detail to understand why neoadjuvant therapy is going to bring a big solution to the problem. So in this German trial, it was demonstrated that adjuvant therapy with correctly dosed ipilimumab, 3 milligrams per kg, plus nivolumab, 1 milligram per kg, and the ipi dosed every 3 weeks, so that's classical dosing of ipilimumab, led to a superior outcome, and therefore was a direct translation of the CheckMate 67 trial of Jan Walchuk, showing superiority of combo ipi plus nivo over monotherapy nivo over monotherapy anti-CTLA-4. The large trial, 2,000 patients, as Sanjiv Agarwala also showed, the CheckMate 915 trial in 2,000 patients was nivo plus ipi versus nivo monotherapy in 2,000 patients, and this was a negative trial. And why was that? Because they took this huge risk to dose ipi at 1 milligram, not okay, and not every 3 weeks, which was what we knew everything about, but at every 6 weeks, which means it was actually only at 0.5 milligrams per kg every 3 weeks. And that is a dose level that is very close to the 0.3 milligrams per kg, which in the old days, 2010, 2011, was demonstrated not to be active. And so I think that's why there was no translation from advanced into adjuvant, because ipi was dosed at the non-effective dose level. So what now? How do we translate ipi plus nivo superiority in the advanced setting into efficacy in an adjuvant setting? And for that, you need to change the paradigm, and you need to go to the neoadjuvant therapy regimens in initially palpable nodal disease, so stage 3C, 3D patients, and resected stage 4 patients, to demonstrate how effective immunocombo neoadjuvant therapy is. And it is actually phenomenal. So on top, you see, you do surgery first, and then you give adjuvant therapy. At the bottom, you see, you have palpable nodal disease, you give neoadjuvant, you get a good response, you do surgery on either just an indicator node, or you do a lymph node dissection, and you find out that you get high rates of major responses with immunocombo therapy. So let's look at the data. Because now you have lots of material to evaluate pathologically. And so you can have a pathologic complete response, a pathologic near complete response, that means more than 90% necrosis, that probably means that if you would have done the surgery 2 weeks later or 3 weeks later, you might have had 100% necrosis, or you have a major PR bigger than 50% necrosis, or you have a non-responder that's less than 50% necrosis. So let's look at the data. So what we promise with neoadjuvant therapy development is more cures, shorter treatment cycles, and less surgery. So you are going to get 3 times the bonus out of this new neoadjuvant approach. And where is it all started? In palpable macroscopic stage 3 melanoma and resectable stage 4 melanoma. But it's now been spread into the highly effective demonstrations of activity in MSI colorectal cancer, T3 bladder wall invasive cancers, locally advanced squamous cell cutaneous cancers. And now there's multiple trials across the board in all pathologies. So this slide shows you the fundamental biologic observation that makes you understand why neoadjuvant therapy is a very good idea. So they started at the NKI, Christian Blank and Ton Schumacher in Amsterdam, in doing a randomized study of patients with palpable nodal disease. Either you do your traditional approach surgery first, and then you give adjuvant, in this case, 4 courses of P, 3 milligrams per kg, plus Nivo, 1 milligram per kg. You harvest your PBMCs and you do TCR analysis. So you do the neoantigen and T cell clones analysis. Or patients got 2 cycles of Ipi-Nivo first, and then got their lymph node dissection. And you sampled for PBMC in the neoadjuvant period before and after neoadjuvant. And then on the right-hand side on this slide, you see with the adjuvant Ipi-Nivo, you got a certain pattern of amplification of clones already present at baseline, dark red, or clones newly detected because of the Ipi-Nivo treatment. Now look what happens in the blue bars, representing what happened in the neoadjuvant treated patients. You see both a very significant increase in amplification of clones that were already present, and a very important, significant increase in diversity of T cell clones representing neoantigens. And so you work with the tumor load in the lymph nodes, and you create a much better T cell diversity army. And you know, diversity is what we need to cure people, and amplification of T cell clones. And they found out that you can give in this setting Ipi 1 milligram in the combination with Nivo 3. That's the flipped dose approach, and you reduce your immune-related adverse events to 20%, and it was much higher. It was like above 60%. And now look at these curves. Look, especially, so now you see at 2 years, there was only 17% patients who had relapsed. Look at the right-hand curves. If you had a pathologic complete or near complete response, you're on the green curve. As a palpable nodal patient, 64 patients, there was only 1 patient who relapsed in the category who had a pathologic complete or near complete remission. And that means a relapse rate of 3.1%. We have never, ever seen these type of curves in patients with palpable nodal disease ever in the history of melanoma therapy. And so this indicates that neoadjuvant therapy is going to cure a significantly higher percentage of patients with very bad disease. So there's a pooled data analysis by the INMC, International Neoadjuvant Melanoma Consortium, of data of, Philadelphia and MD Anderson, Sydney, Amsterdam, and now look at the superiority of immunotherapy combo approach. If it's anti-PD-1 based, and the combination with Ipi is even better. So look at these top 3 curves. top three curves indicate that if you had a major response, a PR, a pathologic near complete or a pathologic complete response with the neoadjuvant anti-PD-1 or anti-PD-1 plus it, you basically did not see any relapses anymore. Now look at the targeted BRAF-MEK combo protocols that were done in BRAF mutant patients. Because on the left, the immunotherapy is for all patients. On the right, now you see the targeted combo is much less effective. Only if you have a pathologic complete response, you have clear benefit, but there are still significant relapses. It doesn't compare even to the PRs with immunocombo neoadjuvant therapy. If you have a PR or a no response, you basically are in the same category. So it can't stand in the shadow of immunocombo neoadjuvant therapy. So this is absolutely now the way forward, how we change the management of patients with a palpable nodal disease, resectable stage 4 disease. We're not going to resect them anymore. We're just going to treat them all with neoadjuvant therapies. This is now being worked out in clinical trials. Here in the pooled analysis, the top curve is for the immunocombo, and the bottom curve is for monotherapy anti-PD-1. So the trial that is now initiated, in which Amsterdam, Sydney, and the 16 melanoma centers in the Netherlands are participating. The melanoma centers in Australia are participating. MD Anderson and a couple of USA centers. John Wayne Cancer Center, Los Angeles Clinics is participating. With the question, 2 courses of IPI, flat dose, 80 milligrams, Nivo, 240 milligrams every 3 weeks. So this is the flipped dose, right? It represents 1 milligram per kg IPI plus 3 milligrams per kg Nivo in flat dosing, 2 cycles. And then you do, and you randomize versus that or immediately a therapeutic lymph node dissection. And then look, the top outcome. If you have a pathological response that is CR, near CR, or PR, you will just have follow-up. If you don't have that kind of major response, you will have adjuvant Nivo or adjuvant BRAF-MEK in case you are a choice if you are a BRAF mutant patient. And the patients who have therapeutic lymph node dissections up front, they will get adjuvant Nivo therapy in these combo flat doses every 4 weeks. So this trial is now being launched and should give the first proof of principle that neoadjuvant therapies are going to produce superior curves to adjuvant therapy approaches. There's another very important trial that was done to understand why I promised at the beginning of my talk that neoadjuvant therapies would reduce surgical procedures. Well, here's the proof. 99 patients who got 2 courses of ipi-nivo, flipped dose, 1 milligram, 3 milligrams per kg. If you had, and there was a lymph node marker in the largest palpable node of the stage 3 patient. And that was the only node that after the neoadjuvant therapy was taken out. It was then sent in for a pathology. And if you had a PCR or a near pathologic CR, no more lymph node dissection. And just follow up. No more adjuvant therapy. So you can avoid therapeutic lymph node dissections and its deconfigurative sequelae and the lymphodemas and so on, because you are going to see PCRs and near PCRs in 60% of patients. And that would mean 60% of no more therapeutic lymph node dissections. If you had a PR, you would still get your completion lymph node dissection. Just follow up. If you had no response, you are identified as a really bad patient, and you will get surgery and, if necessary, adjuvant radiation therapy and adjuvant therapy. That is what happened in these 99 patients in the Prado trial. And what came out, pathologic response rate, 71%, grade 3/4 immune-related adverse events, 20%, as was predicted. No therapeutic lymph node dissection anymore in 60% of patients. And so this is a phenomenal revolution. So you can also do the combination of nivolumab plus relatlimab. Relatlimab is anti-LAG-3, and it protects you against T-cell exhaustion. And basically, that combination also gives this kind of neoadjuvant response rate, data presented by Amaria from MD Anderson at the last ASCO meeting. And it actually demonstrates that radiographic response rates underestimate the pathologic response rate, because you actually can have more PCRs, pathologic complete responses, than you would have thought by the imaging procedures. And if you have a major response, nobody relapsed in the first 2 years. Nobody relapsed in the first 2 years. So this is now going to be translated into other trials as well. So there's also a randomized phase 2 trial of neoadjuvant pembrolizumab versus no neoadjuvant pembrolizumab in detectable stage 3/4 high-risk melanoma patients. And that is a SWOG trial, and it's now at 50% of its accrual. And there's been a TVAC neoadjuvant study that actually gave, in my view, not very convincing results. At least the results are far inferior to neoadjuvant ipi-nivo. Don't forget, neoadjuvant ipi brings the great diversification of T-cell clones and amplitude of T-cell clones, more than any other approach, because of the two different mechanisms of anti-CTLA-4 and anti-PD-1. So here you see much lower and much higher recurrence rates in stage 3CD, resected stage 4/1A patients. And so I don't personally think that this is going to be a real competitor with ipi-nivo at all. And so then it translates into other pathologies. So T3 bladder cancers, muscle wall invasive tumors. Here are the anti-PD-1s, anti-PD-L1s, and the nivo-ipi combo, and so on. All these trials that are PD-1 based, between 40 and 50% pathologic complete responses. What does that mean? That means that we are not going to do standard vasectomies, bladder resections anymore, Bricker procedures. Look at the salvage of morbidity and all these large surgical procedures. Then you can look here at the third column. We talked about melanoma, we talked about bladder cancer. Now here in MSI colorectal cancer, the study in Amsterdam by John Hane, here's in the middle, showed that 19 out of 20 patients who had an MSI rectal cancer had a pathologic complete response after 2 cycles of ipi-nivo. They were still resected. But now, of course, these patients with MSI rectal cancers are no longer resected. They are followed up by endoscopy and biopsy and MRI. So it's totally remarkable what this revolution will bring. The indication of neoadjuvant ipi-nivo treatments of advanced cutaneous squamous cell cancers, especially in the head and neck region, indicate the same type of 50% pathologic complete responses with this approach. And now we will see what will it bring in lung, head and neck, esophageal, and so on, even in glioblastoma multiforme. So this is where we are. This is where the landscape is going. And I predict that neoadjuvant procedures will replace many adjuvant procedures that we do now, will limit treatment times, and will cure many more people. Thank you very much.
Muchas gracias, Dr. Alexander Agarwala. Thank you very much.
Thank you very much, Dr. Alexander. And we will move on now from the physical venue with Dr. Carlos Avitia.
I'm sorry. It's yours now.
Bueno, muchísimas gracias por estar.
Thank you so much for staying on. And I think that the next presenter needs no introduction, Dr. Charles Weiss. Everybody knows him, an excellent oncological surgeon, head of the MD Anderson Cancer Center. Dr. Balch, welcome, and thank you so much for participating. Muchas gracias y buenas tardes. Primero quiero
Dr. Hector Martinez Said and his executive council of the SMEO for their bold decision to have a hybrid meeting. I'm just delighted to be here and present, representing some of the international speakers, including my two friends, Dr. Agarwala and Dr. Egermont. I'm going to finish this trinity of talks about the surgical management, especially in this era that we now, for the first time, have effective systemic therapy. I'm going to give three presentations about the various presentations of stage 3 melanoma. First, microscopic nodal metastasis detected with a sentinel node biopsy, those with clinically enlarged nodal metastasis, and finally, a new group of patients that may be approached surgically is those patients who present clinically with unresectable nodal disease. And I want to remind our audience that there are three goals of treating regional lymph nodes with surgery, of which the most important is staging and regional disease control. We cannot expect that a local regional treatment per se is going to increase survival rates. So remember that a clinical trial that says we don't increase survival rate with surgery does not mean surgery doesn't have value, but we have to factor in the morbidity and the type of surgery we do in those circumstances where we may not increase survival rates per se, but the staging value and regional disease control is very important, as I'll show you later in this talk. And before we get into the surgery, I think we have to remember that stage 3 melanoma is a very heterogeneous group of patients. So I just want to, for a moment, review some of the 8th edition of the Melanoma Staging Committee led by my colleague, Dr. Jeffrey Gershenwald. So remember, in stage 3 melanoma, we have now 4 stages. There's significant heterogeneity in terms of outcome. This is 10-year survival rate shown in the curves, and that the subset stratification is based upon both the features of the tumor and of the nodes, including tumor thickness and ulceration of the primary melanoma, and importantly, the number of lymph nodes that are present, and as I'll show you in a moment, the tumor volume. But if one looks at the 10-year survival rates of these patients, you can see, and we'll come back to this later, that the stage 3A patients have a 10-year survival rate of 88% according to this data. That means in a patient you're seeing today with 3A melanoma, especially with low volume tumor in their sentinel node, the prospects of them having distant disease and dying from that is 12% or less. And that's why I think we have to be conservative in those patients. I agree with Dr. Agarwala. There are some of our stage 2 patients that actually have a much higher risk and should be treated with adjuvant immunotherapy, as he discussed. So in these next 2 slides just shows you the diversity of outcome based upon the number of metastatic lymph nodes. And as you can see, a patient who has 1 metastatic node, especially subclinical disease, they do very well with a 96% 10-year survival rate. But as the number of lymph nodes that are positive increases, the survival goes down. And we need to take that into account when we're seeing our patients, and then taking into account what type of surgery, the benefit and risk of systemic therapy. And then also, I think this is a very important insight of the tumor volume in the sentinel node. Remember in the DCOG study and the American study that the majority of patients entered into the sentinel lymph node, the MELANOMA-SMEO2021 trial, had less than a 2 millimeter volume of tumor. And as you can see, the natural history of this is that these patients do very well. So it might not surprise you that survival rate is not increased by doing more surgery. But on the other hand, as you can see, as the tumor volume increases, survival rate, and therefore the risk of metastatic disease in additional lymph nodes or at distant sites, increase. And in this, just as an example, shows you the marked difference in tumor volume in the sentinel node comparing 1 or 2 millimeter volume versus more than that. So again, this needs to be taken into account in the design and interpretation of our clinical trials and decisions you make when you are seeing patients. So let's dive in for a moment about the role of surgery in these patients who have microscopic nodal disease. All of you know the results of the MELANOMA-SMEO2021 trial and the DCOG trial. I won't go into the details of this, but just to remind ourselves that the randomized trial showed that a completion node dissection in sentinel node positive patients increased the rate of regional disease control and provided prognostic and staging information. But it did not increase melanoma-specific survival. So some of our friends and pundits have said, since it doesn't increase survival, then maybe we shouldn't do surgery at all. But as I showed you in the other slide, that negates what is, I think, a benefit in clinical decision-making for regional disease control and staging. And in this slide, just from the New England Journal of Medicine paper, you can see that those thicker tumors, and especially the presence of ulceration, correlated with outcome. And at the bottom, what is very important, there was a highly significant difference in outcome based upon whether there were non-sentinel lymph nodes that were metastatic versus those patients who only had the sentinel node positive. So how to interpret these clinical trials? Option 1 is there's no survival benefit of lymphadenectomy, and therefore sentinel node dissection should not be performed in any patient who is sentinel node positive. But remember, it's paradoxical. If there was a 10 millimeter lymph node that was detected by ultrasound, and we confirmed that, the standard of care would be to do a completion lymphadenectomy. So we have to keep this in mind. I think it depends upon tumor volume and other features of the melanoma, as I'll show later. So I think option 2 in interpreting these trials is there was a selection bias for entering patients into the trial who had little risk of spread to other non-sentinel lymph nodes. And this was in at least 2/3 of the patients entered into the trial. So I don't think that we can make a blanket interpretation is that there's no value in patients with sentinel node positive disease. It depends upon some other features. And I would encourage us as we're making these decisions to be selective based upon prognostic factors that I'll go over in a few moments. I think it's also clear if one looks at the MELANOMA-SMEO2021 and MELANOMA-SMEO2021 trial that removal of metastasis in the sentinel node is probably therapeutic. And this explains to me, and I think to many others, why MELANOMA-SMEO2021 showed a survival benefit, but MELANOMA-SMEO2021 did not show a survival benefit because you'd already removed the single sentinel lymph node, and there weren't many patients who had non-sentinel lymph nodes left. So it does say that the sentinel node biopsy is important in our patients, regardless of whether we go on and do a completion node dissection. So the key point here is that patient survival is only one objective of surgery, and it's equally important, in my view, that the value of staging and regional disease control, when it applies to our individual patients in our practice, should be taken into consideration. And also remember that these patients in the trial had follow-up with ultrasound rather than just clinical palpation, which is not as accurate. And this must be available for the patients coming back and having ultrasound guidance for early treatment of their nodal relapse if they occur. So the value, just to summarize, for completion node dissection in sentinel node patients is it does virtually eliminate the future risk of nodal recurrences, which is much lower in patients who present later on with clinically palpable recurrent disease and usually multiple lymph nodes. So therefore, it virtually eliminates the need for adjuvant radiation therapy, which can have some issues with costs and lymphedema that we would use in patients with 4 or more positive nodes, which, as I pointed out here in the MSLT1 trial, 27% of patients who had clinical follow-up only and then relapsed, 27% had 4 or more positive nodes, which would be a consideration for adjuvant radiation therapy after surgery. And then also in patients who have surgery for palpable nodal disease, have a higher incidence of wound complication, and as I'll show you in one of the other slides, a higher rate of lymphedema. Now, just to give a balanced perspective here, this is a publication from Europe in which they looked at whether the completion node dissection improves the staging accuracy. And in their patients that was referred to their institution, there was a change of disease stage in less than 6%. Other series had a change in disease stage of between 10 and 17%. So again, it depends upon your practice and the kind of patients who are coming into your practice. But just for balance, I think this is important to point out as well. I also want to point out a very important study, again led by Jeff Gershenwald some years ago, in which he looked at the tumor volume and the risk of non-sentinel lymph nodes. And the key point here is in patients who had 2 to 10 millimeter tumors had a 25% risk of non-sentinel metastasis, and more than 10 millimeters had almost a 46% risk of nodal metastasis. So again, to me, saying all sentinel node patients do not need a completion lymphadenectomy is not a proper interpretation of the clinical trials, and that we need to be selective. And this, just to go over a few issues about the risk of waiting and doing a node dissection for patients who present with clinically palpable disease, where we don't do this right after a sentinel node procedure. There's several things just to point out so we understand the risk of not doing a clinical node dissection and can take that into account when making our decisions in individual patients. So in this study, it found that in patients who had a clinical node dissection, a therapeutic node dissection, either immediately after a sentinel node or did not have this immediately and had it later on, that those patients who had a delayed completion lymphadenectomy had a higher rate of recurrences in the nodal basin than those patients who who had that immediately. And even in terms of recurrence-free survival, as you can see, there's a diminution in survival, not a big one, but there is a diminution in survival in patients who had a delayed clinical node dissection and who then had salvage therapy. And as this study showed that in patients who had a in-basin recurrence after a completion node dissection, if it was immediately after a sentinel node dissection, it was 6%. If it was later on, it was 13%. And this presentation at this year's SSO meeting from Dr. Mark Ferries and his group again shows that as the number of risk factors increase, the probability of regional disease control decreases. And as you can see, these factors that were examined were older age, presence of ulceration, thicker tumors, non-axillary basin tumors, ectopic nodes, and greater than 1 millimeter volume in the metastatic area. And as the number of those features lined up, then the risk of not getting regional disease control with a delay goes down. And this to me makes the point that maybe we should be selective in some patients who present with increased risk factors. And then finally, as I mentioned earlier, in patients who have a completion node dissection for clinically positive disease in the MSLT1 trial had a higher risk of lymphedema, especially in older patients, obese patients, and those having a groin lymphadenectomy. And then finally, I think this is our future, as we've talked about. If we're going to not do a completion node dissection, now that we have effective systemic therapy, that maybe adjuvant therapy will deal with the metastatic disease, including in the lymph nodes. This is very similar to the Z11 trial in breast cancer, where we're no longer doing completion lymph node dissection in sentinel node positive patients for breast cancer. So in this trial, which is not randomized, but it's the only data we have, you can see that adjuvant systemic therapy in these patients who had sentinel node biopsy only and did not have a completion node dissection, and there was some selection bias of patients getting into the trial, that there was an improved survival with adjuvant therapy compared to those who only had sentinel node biopsy and no completion lymphadenectomy. So this makes sense of combining the treatments of surgery and then giving adjuvant therapy when we have effective agents in treating both distant and, in this case, probably regional metastatic disease. These kind of studies have to be confirmed with the studies that you heard by our previous speakers, but at least this is the data that is present. And I point out this paper was published just 2 months ago, so this is very recent data, and it's the best data that we have right now. So, in a patient who has metastasis in their sentinel lymph node, it would be my consideration to perform a completion lymph node dissection selectively in those patients where, one, there's sufficient risk of non-sentinel metastasis, two, the staging information would be of value of determining further therapy or for counseling patients about prognosis, and three, long-term follow-up with ultrasound is not feasible in individual patients. But when not to do this in individual patients who are sentinel node positive, it's basically what we do in our practice every day. When the benefits of doing a completion node dissection for staging and regional disease control, not survival, do not outweigh the risk of complications and morbidity in our individual patients. Patients who have significant life-limiting comorbidity with other diseases. Those patients with significantly increased risk for extremity lymphedema, especially groin dissection, when the tumor burden in the sentinel node is small and the features of the primary melanoma are favorable, and therefore the probability of having non-sentinel lymph nodes in the region is small. And then also those patients who can have long-term follow-up with ultrasound. So in the last 10 minutes, let me just go over the other presentations. You've heard a lot from Dr. Egermont and Dr. Agarwala about the management of these patients with stage 3B, 3C, and 3D. And I'll just briefly go over this, which reinforces their message in these patients. So the standards of care today, for many of you in your practice, especially if you don't have the availability of these targeted therapies or these checkpoint inhibitors, is upfront surgery and the selective use of adjuvant radiation or systemic therapy, which I won't go into. You heard the discussions before. These are the approved treatments today. But I totally agree with Dr. Egermont. The future in virtually all of our patients with clinically node-positive disease is with systemic neoadjuvant therapy. Look at how we're treating triple-negative breast cancer. Virtually everybody now gets molecular diagnosis, neoadjuvant therapy. If they have residual disease, we change our treatment based upon the molecular profile of the refractory disease. This is where we're heading now in melanoma, now that we have these new and effective tools, which, as Dr. Egermont says, this is a revolutionary change in our management of melanoma. So just to reinforce his message, the advantages of neoadjuvant therapy is, one, It downstages tumor and increases the ease of surgical resection. We can now use pathological response as a surrogate endpoint for long-term benefit. Those results are clearly shown in breast cancer and others, and the results so far in melanoma are the same, that PCR or near PCR is a surrogate marker for long-term survival. And just as Dr. Egermont said, in our experience at MD Anderson, a patient getting immunotherapy with a checkpoint inhibitor for stage 3 or resected stage 4, and who gets a PCR, almost no one relapses, even with long-term survival. This is remarkable. It has never happened in our experience of melanoma research. This also allows us with neoadjuvant therapy to test novel combination strategies and investigational drugs, and then have surgical samples before and after the exposure to these systemic agents, so that then in patients who don't have a complete response, we can examine the molecular profile of those cells left behind, and as we do in breast cancer, change our strategies in adjuvant therapy. And then the improved response rates from studies in patients with advanced regional disease, since neoadjuvant patients are less likely to have been heavily pretreated and less immunosuppressed. So the results you're seeing in stage 4 disease, we're even going to get better results with these same agents in neoadjuvant therapy. And this is a very important, to me, explanation why neoadjuvant therapy is going to be better than adjuvant therapy when we're using checkpoint inhibitors and unleashing the immune response to recognize the metastatic tumor as foreign and reject it as it would for viruses or transplanted tissues. In this excellent article, which I would commend to you, you can see that if we do remove the tumor first and then give adjuvant therapy, there may not be very many metastatic cells left behind to stimulate the immune system. Whereas if you give neoadjuvant therapy, the entire tumor and the repertoire of its heterogeneity is available to the immune system with these checkpoint inhibitors, and therefore a more robust and a diverse immune response to all of the antigens reflected on these primary and metastatic cells will be exposed, and the immune response is theoretically going to be stronger. And I think the evidence so far fulfills that hypothesis. So as you've heard from Dr. Agarwala and Dr. Egermont, that there's strong rationale using these agents which have proved to increase survival rates dramatically in an adjuvant study, and then using these in a neoadjuvant setting. And a key point here that Dr. Egermont said, the value of surgery, whether we do a more complete lymphadenectomy or a partial lymphadenectomy, is very important for staging, because you cannot radiologically assess whether you have a PCR or not. So therefore, surgical excision of the disease that presented with palpable disease is important and critical to understanding whether or not we're going to get a better survival and what we should do to the patient afterwards. And there's even preclinical data, and one paper recently published demonstrating that neoadjuvant therapy has an improved survival rate compared to the same drugs given after surgery. Just to go over a few things to demonstrate the incredible power of these checkpoint inhibitors from the standpoint of prognosis and staging, here's an earlier trial from the Mayo Clinic giving a single dose of nivolumab, predicting clinical outcome. And it's remarkable, after one dose in patients with palpable stage 3 disease, 30% of patients had a complete or near complete response with one dose. And among those patients, none of them had relapsed over 3 years. This is important about the PCR or near PCR rate being a surrogate for long-term survival. And then this trial that was conducted at MD Anderson, a phase 2 randomized trial in BRAF mutant patients getting BRAF MEK inhibitors before and after surgery compared to those who had the standard of care with adjuvant BRAF/MEK. This study, which was conducted after only 20-some patients, was stopped by our Data Safety Monitoring Committee because the pathological complete response was 62%, and the survival rate of these patients was so much better than the standard of care that the study was stopped, and this was published in Lancet Oncology. And you might say this is a small trial, but here again, look at the difference in patients who had a complete response, the green bar. There were no relapses in these patients after 2 years. Now, the Australians, led by Georgina Long, did a verifying trial using the same patients and the same drugs, BRAF, MEK, and those patients who had a BRAF mutant positive patients. And I won't go over the data other than to say these two trials were very significant. The pathological complete response in these patients was almost 50%. Dr. Egermont went over the Opacin trials, so I won't go over this very much other than to show you the group B is the one you want to pay attention to. This is 3 milligrams of IPI, 1 milligram of Nivo. 77% had a pathological response in the group B, and 57% of those were complete responses. And in terms of toxicity, this was also the lowest toxicity among the other regimens used. And again, pointing out that those patients who had a response did so much better, significantly better, by a factor of 50% compared to those who did not. And then in this non-randomized trial from Penn, comparing patients with melanoma who had the same drugs, but one was neoadjuvant, the other was adjuvant, that you could see in the yellow line on the left-hand, on the right-hand side, the patients who had the neoadjuvant therapy did better in this non-randomized trial. This is the only outcome we have to date than those patients who had adjuvant therapy. But the other column is very important. If one looks at the survival of patients who had a PCR or near PCR, again, the yellow line, it did better than the patients who had any form of adjuvant therapy and those patients who had neoadjuvant therapy but did not have a PCR or near PCR response. So finally, in the last few minutes, I want to go over a new group of patients that we couldn't operate on before, but now we have these effective agents, and it opens up a new indication for patients with clinically unresectable nodal metastasis. And the key point here, as I told you, this is an example from Dr. Ross of a patient who had bulky disease in the groin and iliac area, judged to be unresectable, had nivolumab therapy, and after that immunotherapy, you could see there was a reduction, but it still would only be counted as a partial response radiologically. However, it did allow the surgery to be performed, and at surgery, there was no residual disease. This was a false positive response, and in fact, this patient had a pathological complete response. What we were seeing on X-ray was scar tissue and inflammation, not viable tumor. So just to show you, there's several papers in the last few years demonstrating, here again from the Mayo Clinic, a small study, an early one, 5 of 7 unresectable patients were converted to resectable. And in this publication, a larger group of patients, surgically unresectable disease, this was published in the Annals of Surgery in August of this year, 81% of these were converted from unresectable to resectable disease and had an R0 resection. And again, this is yet another paper of unresectable stage 3 and stage 4 melanoma who were converted to resectable. And it gets back to one of the things both Dr. Agarwala and Dr. Egermont had said. If one compares the outcome in this pooled data, comparing immunotherapy versus targeted therapy, every way we look at the data, patients who got immunotherapy had better survival rates and longer duration of survival, whereas those with targeted therapies did well at first, but then the tumor cells escaped and we had late recurrences. And this just shows in this last this study I just quoted, if you compare the immunotherapy, those patients who had a PCR in the green lines did very well with immunotherapy. They also, with targeted therapy, did better than the control. But if you look at the green lines with targeted therapy, they're not the same duration or magnitude as in patients getting immunotherapy. And then finally, one other new indication is a patient who gets adjuvant therapy, did not have a completion lymph node dissection, and then relapses after adjuvant therapy. And again, this shows that these patients may be candidates for surgery and then continuation of immunotherapy. And in this trial, you could see that patients who had targeted therapy versus immunotherapy did not do as well. And those patients who were resected to NED did much better than those that you could not do a R0 resection. So this is my summary slide, and it complements what you've heard from Dr. Agarwala and Dr. Egermont, that when checkpoint inhibitors and targeted therapy have changed the entire paradigm of management of stage 3 melanoma, and we as surgeons need to take this into account. Even if you don't have it in your practice right now, I guarantee you this is going to be our future for all of us because these agents are so effective, and hopefully they'll be more available and affordable here in Mexico. Completion node dissection is no longer necessary for most sentinel node positive patients. However, I would argue that higher risk patients might benefit from both the regional disease control and the staging value. Neoadjuvant therapy is emerging and will be the future standard of care for most clinically positive patients. And even unresectable stage 3 patients can be converted to operable with neoadjuvant therapy, as was demonstrated. We didn't have time to go over adjuvant radiation therapy, but this is just another issue that in a randomized study reduces recurrence rates in patients at high risk, but did not increase survival rate. It's another discussion. We've all said now that we have these new tools that clinical trials with new combinations and sequences is going to be important, and I hope all of you, where you can, will participate in those. And my bottom line message is these systemic agents are effective, but surgery is not going away. It actually is going to be very important, but in a different group of patients for both staging and regional disease control. Muchas gracias.
Bueno, muchísimas gracias.
Thank you very much. We will now conclude with our module. And our Dr. Victor Manuel Oyorvides, medical oncologist who is a member of the University Monterrey Hospital and who has private practice. He is a physician very interested in the management of melanoma, and he has experience in clinical trials. So please, Victor, thank you very much for accepting our invitation to participate here today. Thank you very much, Miguel, for this introduction. And I am left always with the most difficult topics and the most complicated scenarios, but it's a real pleasure to talk to you. As medical oncologists, the central nervous system metastasis scenario is something that we never want to tackle or face because it might be quite catastrophic from a clinical standpoint and also prognosis for survival and for the patient's function as well. Despite the fact that clinical current trials with the new drugs for immunotherapy or targeted treatment that we have available are still quite deficient for the adequate control of these type of metastasis in the central nervous system. I will try to be quite specific because we are in the hypoglycemia stage prior to eating. These are my disclosures. We know that at diagnosis, 10 to 20% of patients who will debut with metastatic disease will show brain metastasis or central nervous system metastasis. And we know that up to 50% of patients during the course of the disease, they will have progression to the central nervous system. We know that this is a common failure treatment site, and this because of the pharmacokinetics and pharmacodynamics of the drugs that we use. Despite using the best targeted therapy and immunotherapy, half of the patients will progress to central nervous system. We know that the median overall survival when a patient debuts or progresses to central nervous system will be around 4 months. And evidently, we know that all drugs are going to have poor penetrance to the CNS because of the blood barrier. So the survival of these patients at the debut of the disease or where they progress to their treatments is going to be very poor. The risk factor for CNS metastasis might be quite specific and that appear more commonly in males in earlier ages of the presentation of disease. The primary site of melanoma in the CSN is the scalp, and the higher the mitotic cell counting, the patients might show higher risk. And of course, the greater stage of the disease debut is a risk that is much stronger for failure to central nervous system treatment. Some other studies have shown that some BRAF mutations or NRAS mutated or the losses of PTEN have been associated to worse prognosis factor for metastatic disease in the central nervous system. There are several considerations that we have to consider for systemic therapy in this group of patients who are debuting or have metastatic disease during the progression to the leptomeninges or the brain. It is a dilemma, the use of steroids in symptomatic metastasis. Most of the clinical trials, as you recall, and even the previous one, do not allow, in most of the cases, have use of cortisone or any other steroid derivative more than 10 milligrams of prednisone or its equivalent. This has been considered an exclusion criteria for the trials. Combination of immunotherapy with radiotherapy is a factor to consider, and particularly those trials with targeted therapy. Of course, it's the duration of response in those trials that give combination therapy or targeted therapy. It's going to be quite poor from a pronostical standpoint. The combination of these two with the immunotherapy and the mechanisms of resistance. We know that the multidisciplinary management of these patients is key because we have to involve the neurosurgery and radiotherapy departments to provide care to these patients. Historically, this is what happens. The largest responses rates that we had with monodrug therapy, and we have with temozolomide. However, the responses in the central nervous system are quite poor from a clinical standpoint. Likewise, the survival rates are very poor, and patients usually evolve freely with failure to these treatments in the short term. Then we have immunotherapy trials. Monodrug agents that were studied in these trials, the main one was with ipilimumab, and it seems that with these cutoffs with ipilimumab at 10 milligrams per kilo high dosage, patients were divided in cohort A, where the patients had CNS metastasis but was asymptomatic, and the cohort B allowed steroid usage, but these are poor recruitment of subjects in these trials, and these cohorts with asymptomatic patients and large doses of ipilimumab of 10 milligrams showed objective responses in the CNS up to 18%. In cohorts B, which are symptomatic patients, the response with monodrugs with ipilimumab were very poor. Control of disease in CNS was quite poor in both cohorts, but the worst prognosis will be for those patients who are symptomatic. Overall survival that ipilimumab showed in the use of monodrug would not move further than 7 months. So it's been used as monodrug with pembrolizumab, where we had objective response rates of around 20% of cases only, with poor recruitment of patients. And this cohort of patients with pembrolizumab allowed only patients who did not require steroids, and of course they should be asymptomatic from a CNS standpoint. Then the Nivo-EP combinations emerged. This trial, the ABC, that has given us recent results that combine several treatment groups. Nivo plus EB, Nivo at 1 with EP3, and monodrug with nivolumab. And the PFS, intracranial PFS in these subjects was around a year of treatment, usually with control in the combination group of the 49% versus 20% in the monodrug group. However, these patients should be asymptomatics without the use of steroids nor previous radiotherapies. And of course, the survival that was obtained was quite poor. The objective response rates that were obtained with the combination treatment, NIVI and EPO, was only in half of the patients. However, there are results of complete responses and partial responses, but they were quite poor in terms of prognosis. Another of the trials that combine EP plus Nivo and 3 milligrams EP, 1 milligram Nivo, and Checkmate 204 divided patients in 2 cohorts, asymptomatic cohorts and symptomatic cohort. And based on the previous assays where the objective response rate was in half of the patient, in contrast, in asymptomatic patients where objective responses, those patients who were using steroids or were symptomatic from a neurological standpoint, was only around 20% of the patients. Regarding targeted therapy, we have some data. This trial, the COMBI-MB, is a phase 2 trial that evidently is directed towards BRAF mutation, DABRA plus trametinib. These were cohorts of CNS metastasis previously or not previously treated, and this trial allowed patients to using steroids. In cohort A, we had objective response rates within CNS of 50% of patients, very similar to what immunotherapy provides. And the disease control rates, were around 78%. What's interesting in these patients is that there was progression even with treatment in some subjects, both intracranially and extracranially. Most of them showed a progression intracranially wise. So the effectiveness of this cohort of patients was just half of the patients, and the duration of response, which is something that is quite controversial with the use of targeted therapy, which only lasts like 6 months. This is a phase 2 trial as well that studies the effects of the CNS of encorafenib with venetoclax, and this directed to BRAF in symptomatic and asymptomatic cohorts with the use or without the use of steroids. And the best response rates that we found in symptomatic patients are a bit higher, 10% additional to the previous combination, up to 24% of patients. In symptomatic patients, it also provides greater benefit in these patients who had the for steroid up to 63% of patients. In those patients who required radiotherapy after 2 months, because this was part of the phase 2, that they would receive 2 cycles with the BRAF, anti-BRAF combination, and then they receive radiotherapy. They would continue with the symptomatic control of patients in a positive fashion. Online results, as I described, were symptomatic efficacy. Toxicity is quite easy to manage. Comparatives with immunotherapy versus targeted treatment, you can see the comparison of the 2 trials, basically using the same drugs, and comparing it indirectly to the results by COMBI-MB, the outcomes are quite similar. The interesting thing of this comparison is that there is higher response rates, slightly higher response rates, but when indirectly comparing the duration of response, they are quite similar in both groups of treatment. Strategies to increase the duration of treatment and targeted treatment. I think that maybe increasing the dose could be a positive response. The BRAF inhibitors should penetrate better the BBB, and there's a phase 1 trial. Targeted therapy with immunotherapy that could be a good combination from a clinical standpoint and can increase the response rates and better symptomatic control of patients. These are studies that we might probably be seeing with more sound results. The Credence is another study, phase 2, that combines in this stage of treatment 2 types of patients. Those without metastasis, systemic metastasis, and those who are refractory to PD-1 treatments. And the best control responses have been 90%, and PD-1 refractory, there has been 88% responses compared to the PD-1 naive, which have had almost 100% response to this combination. Brain mets have shown control of the response in up to 89% of patients, and patients without brain mets, almost 94% with ORR. So duration of response has been a bit significant, but they move around the same figures than in the previous studies with immunotherapy or targeted therapy. Some of the other trials ongoing at present and look at how they are focusing on combination therapy. Most probably we will have some results in the next few years, but they need to continue maturing. One of the clinical trials that I believe will have one of the best effectiveness is the use of anti-angiogenic treatments in this type of patients together with targeted therapy. However, the studies have to mature before. Multidisciplinary management has to be very important in this kind of treatments. Surgery, we know, is potentially curing in oligometastatic disease. We need to assess our patients always when they have metastatic disease to the central nervous system with a multidisciplinary treatment management. Radiotherapy should be pancranial and stereotactic radiotherapy that will allow us to preserve the hippocampal function and add some benefit from some standpoint of nervous system symptoms in these patients. These are going to be regimens with combination radiotherapy and immunotherapy and targeted therapy. This is a sample of a meta-analysis of 534 patients that showed that 1-year survival was around 64% of them, 51% of the patients for concurrent therapy versus non-concurrent therapy. So there is a statistically significant difference in those patients who arrived with the concurrent treatment versus the non-concurrent group. At 1 year, there was 89 versus 68% respectively for those patients without concurrent treatment. Concurrency could be associated with higher efficacy and similar safety of patients. These are ongoing trials in combination with radiotherapy. Are several. We are going to be assessing safety and penetrance to the BBB, but in the immediate future, we will be able to see the results of these treatments. I could conclude by saying that immunotherapy has its strengths with an objective response rate up to 50% of the patient. Its weakness is that 30 to 40% show progression rates with some toxicity, and the activity in symptomatic patients is reduced. And we've seen this in a group of patients who have been analyzed in the trials. Targeted therapies show rapid responses with control of the initial or early stage, even in patients who are symptomatic and are using steroids, but responses are not going to go beyond 6 months. Of course, we need more information with the use of other combo, and we are going to be observing the new combination in combinations of immunotherapy and targeted combinations and sequencing with radiotherapies, which is something that we are going to be resulting. New metastasis with less infiltrates and some phenotypes of the brain that are going to be assessed, and new strategies in current studies, radiotherapy plus immunotherapy, P13, P3K, AKT inhibitors, and OX-FOS inhibitors. So I believe that the flow chart of management of metastasis in the central nervous system due to melanoma can be approached in this way. Metastatic disease at debut with a scenario where the patient is not using steroids or does not require more than 10 milligrams of prednisone or its equivalent, or the other one is progression to the first line treatment. In terms of metastatic debut disease, we have to assess whether the patients are symptomatic or asymptomatic. And this group of patients, if we assess the BRAF mutations, if they are negative, the first option for treatment could be the combination therapy with immunotherapy and radiotherapy, plus minus. In patients with present mutations, targeted treatment inhibitors that are available for this group of patients would be our first line, and assess the sequentiality of treatment. In patients who are candidate to systemic treatment, surgery might be a treatment option, assessed, of course, by a multidisciplinary team, followed by radiotherapy and systemic treatment. Always consider palliative care in these patients when they are very symptomatic at debut, because we can only offer maybe palliative radiotherapy. In terms of progression to first line after systemic treatment, we need to assess surgery and radiotherapy, particularly with radiosurgery, and then a systemic treatment depending on whether the mutation is present or not. Always consider in these type of patients the performance status, the previous treatment in the first line, and the comorbidities that the patient may show in order to protect them from adverse events that any type of treatment could have. Thank you very much.
Gracias. Pavel, ¿me acompañas, por favor?
Would you join me, Pavel? I think that this has been a great session. Dr. Alexander, thank you. Dr. Schwang, Thank you, Sanjiv. I think that it's been a very interesting session, and we're talking about treatment of melanoma with a future view. As Dr. Alsh said, there are many more patients being cured. I'd like to start with the next question in the scenario of adjuvancy for Dr. Sanjiv Agarwala, and also for Dr. Valero and high risk stage 2 B and C particularly. In patients with these characteristics for high risk stage 2 disease, could we consider immunotherapy at present as a standard of treatment based on your perspective, Dr. Egermont and Dr. Agarwala?
So I think I had shown in my presentation the results that were presented recently at ESMO for Keynote 716, which showed that monotherapy with pembrolizumab is effective for patients with stage 2B and 2C disease. We don't have the FDA approval yet, but certainly the data is there. So the answer is yes. I think particularly for stage 2C disease, I would be immediately treating my patients with at least monotherapy with pembrolizumab, and I have no doubt that nivolumab will show the same result. For 2B as well, I think, certainly their prognosis is not as bad as 2C, but it's worse than 2A. The approval, I think, when it comes, it will come for all stage 2 disease, because that's how the FDA works in the US. They go by the trial eligibility, which is all stage 2 disease. So it will be available to us for all stage 2 patients. I think the question is, will we select among them or treat all stage 2 patients? For my part, I don't think I will be offering it to stage 2A at this point in time. There were only a few patients on the trial with 2A disease. And I would love to hear what others on the panel think about that. But for 2C disease, I think it's very clear. 2B, it's in between, and 2A, for me, I would not offer it.
Yeah, I'd like to add to Sanjiv that what happened in stage 3 disease was that the approval was there for all of stage 3 disease, although in the stage 3 trials, the ipilimumab trial, the BRAF-MEK combo trial, and the pembrolizumab trial, we had a caveat for the stage 3A patients that the tumor load in the sentinel node had to be larger in a diameter of 1 millimeter, according to the Rotterdam criteria. That required a specific additional evaluation by the pathologists. And there I thought that FDA was rather practical and say, we're going to approve it for all of stage 3. For stage 2, I think it's going to be quite different. I think for stage 2, 50% of stage 2 patients is stage 2A, who really have a significantly better prognosis than the stage 2BC patients. Stage 2B and stage 2C patients have a relapse rate of 25 to 50% over the first 5 years, and therefore are clear candidates, when you look at the overall relapse rate, to be considered candidates for adjuvant therapy. At least you have a discussion. For stage 2A patients, this is only 12%. I think there, and so I expect FDA to not go the same way. I do not expect FDA to approve for all of stage 2. I think it would be a mistake. I think it would be a serious mistake leading to overtreatment of stage 2A patients, where the risk benefit is distinctly different. But I do expect it to be approved for stage 2BC, yes, for sure. For stage 2A, I think the landscape will be determined by whether we will have a successful gene profiler a combination with some clinical characteristics that identify the sentinel node negative stage 2A patients to still relapse. I think that will come. And then I think we would have a tool to know which stage 2A patients would be candidates for adjuvant therapy. So that's just a refinement of what Sanjiv was just saying. You think that would be reasonable, Sanjiv, what I just said?
You put it very beautifully. I think that's completely correct. I hope you are right, Lex, that the FDA will not approve for all stage 2 patients. Historically, as you know very well, the FDA has not acted with any intelligence. They have only gone with the trial design and approved drugs according to that. I hope there's no one from FDA on this program, but I hope you're right, because what you described is the correct thing to do. And I think that for stage 2A, and even as we, for stage 1 patients, we don't have any data yet, but we have to refine our biomarkers better and select the patients correctly. I agree with you 100%.
Okay. That's nice of you. Thank you, Sanjiv. I always hope that what I think might be supported, but at least I'm supported by you. This is very
well.
Good
I hope you,
you
perhaps are an advisor to them, perhaps on the ODAC committee. If you are, I would love for you to say what you just said.
Okay, good. Thank you.
Pavel, por favor.
Sí, tenemos una.
We have a couple of questions from our virtual attendees for Dr. Alexander Egermont and Dr. Charles Bosch. The results of neoadjuvant chemotherapy and the reduction of surgeries performed have been placed here. In the scenario of patients with pelvic lymphatic metastasis, in this scenario of immunotherapy, is it still valid to carry out lymphadenectomy? And in what sequence would it be performed, and in what cases? That would be the question.
So I think at this point in time, if Charles allows me to take the first answer to this particular question, is the following. If you have demonstrable macroscopic disease, I would favor, like we are doing now in the Netherlands. So we have 16 clinics in the Netherlands for the whole country that are the melanoma clinics. All the patients who would present with this particular problem would be entering the NADINA trial, which is the neoadjuvant ipi-nivo trial versus adjuvant nivo. And to demonstrate that you could avoid, what we expect is that not only the outcome will be superior by neoadjuvant therapy because of the induction of all these T-cell clones and the variety of T-cell clones, and therefore far fewer lymph node, relapses after a 60% pathologic complete response. And that actually the next step would be that we would demonstrate through that trial also that basically we don't need, with the neoadjuvant approach, in roughly 50 to 60% of the patient population, a lymph node dissection anymore. If you just take a little time to also then either just by a node sample demonstrate that you have a pathologic complete, near complete, or major response, or that you would have a little bit more patients on your PET CT scan to demonstrate that you would actually also have radiologically a complete or near complete response. Those patients we will demonstrate, we expect to demonstrate over the coming years to not need lymph node dissections anymore, that have this pattern of major pathologic response.
Si el doctor.
La única advertencia que yo le daría a la recomendación
To at least remove the disease that presented that was treated by neoadjuvant therapy, because increasingly it's going to be important to know whether there was a complete response or not. And at the present time, there is no other way than histological examination to know that. And this will become more important as we then have the opportunity to look at the refractory or residual cells in patients who do not have a PCR and make a decision whether to change the treatment strategy as adjuvant treatment afterwards, as has been done in breast cancer. in this particular circumstance of iliac metastasis, it is important to achieve regional disease control here. Because if you don't, it's very difficult to treat. You cannot give radiation therapy because of the overlying bowel. These patients then will have compression on their pelvic nerves and their iliac vein and can be very, suffer a lot as they die of distant metastatic disease. So this is one place where we need to do whatever it takes to achieve regional disease control. And I do agree that in our practice, we would do this in all cases with neoadjuvant therapy, probably using the 3-in-1 milligram doses that has been shown to be so effective in combination. And I would point out Dr. Egremont has a wonderful review about neoadjuvant therapy that I would commend to you. And I like the title where it says, "The future is now."
Muchísimas gracias, doctor Álvarez, por sus comentarios. Estamos sobre el tiempo, pero sin
For
embargo,
your comments. And we are almost to adjourn, but I'd like to ask Dr. Victor Ollervides a question. And this in respect to all of you who might be probably hungry already. Very interesting. You have demonstrated, Victor, that if we detect patients with metastatic disease in the central nervous system, but low volume who are asymptomatic, these might be the patients with the highest likelihood of responding to treatment. So the question is very simple here. Do you believe, and I'd like to hear the opinion of all of you, do you think that we have to change our expectations and change to screening studies in all patients with metastatic disease or only for high-risk patients? And as you defined, it's the high-risk criteria for the development of central nervous system metastases are not yet that clear. We are trying for patients to receive much more treatment. And point number 2 is, what is the role of radiotherapy in this group of patients? Should we reserve it for patients who do not respond to systemic treatment, or all patients should be getting it? I'm going to respond first to the second question. I believe that radiotherapy has to be reserved for those patients who are asymptomatic at debut. If this is a disease where there are no neurological secondary data, secondary to the brain activity, we can reserve it and maybe start with a systemic treatment, of course, depending on the risk factors. The symptomatic control that we might have in single lesions that are oligometastatic in the central nervous system, radiotherapy versus symptomatic control with systemic treatment will be 6 months approximately. So I believe that it is worth reserving radiotherapy until they become symptomatic from my own personal standpoint. Now, with regards to the advanced disease, where we are going to make a scrutiny of metastatic disease in the CNS, stages 3, the higher the volume of disease they might have or show, definitely we have to make a more thorough search in order to seek for that metastatic lesion. MRI plays a significant role in the determination of the metastatic disease, and of course, in earlier stages, in higher volume stages 2, and the risk was shown in the charts that I mentioned. The lower the volume of disease in stage 3 may have the highest capacity of metastasizing to the central nervous system. Any further comments? Sanjiv? Alexander?
No, not really. I think right now Ipi/Nivo in first line for brain metastases is by far the first option to look at. And so, I mean, it does as well as it does for extracranial metastatic disease. I mean, it's phenomenal. So indeed, the order of things have changed, and basically all presentations, also of resectable stage 4 disease, whether it's brain or visceral metastases, is going to be treated first with immunocombo, and then only after that you will look at something else. And that's basically the way we are living right now.
I agree, and I would add to that just one more fact, that especially for asymptomatic patients, the data are incredible. You know, for symptomatic patients, it's a little bit worse.
Yeah.
And certainly for someone who needs steroids, I hope they're BRAF positive so I can put them on targeted therapy. But for asymptomatic patients, Ipi/Nivo, it's amazing. You know, for a medical oncologist that has lost many patients to brain metastases in my career, it's incredible to see this. So absolutely, yes, I agree.
Yeah, I'd only add to your second question that we want to avoid whole brain irradiation except as a last resort. And remember that in current neurosurgery technology, with navigation devices, MRIs in the operating room, you can safely remove a limited number of metastases almost anywhere in the brain, and then follow that, if necessary, with stereotactic radiation. Or in some patients, if it's not resectable, to use stereotactic radiation if there's limited volume, and hold whole brain irradiation for a last resort.
Muchas gracias.
Recurso.
Pues bueno, Pavel, por favor.
Abel, would you like to? I think that I would like to thank you enormously to our 4 speakers for their participation. Hopefully we will be joining with you sometime soon. And with this, I'd like to adjourn this module of our conference, Skin and Melanoma. Thank you to our speakers. Thank you to all the attendees, and have a great evening.
Thank you.
And after.
Very
Thank you.
good. Bye-bye.